here at Northwestern, and I want to give a talk about the power of HPV vaccines and cervical cancer screening. I know this is kind of a broad topic and kind of geared towards younger patients, but I think it's a really important and powerful tool that we have in preventing and screening for cancer. Really powerful success story. So here's how I'll start. I'll start with a big screen on cancer statistics for cervical cancer. Cervical cancer is the third most common gynecologic cancer in the United States, but the most common GYN cancer worldwide. And that's, we've downgraded it dramatically here owing to the success of our cervical cancer screening. But despite how great we are at screening and prevention, there's still going to be an estimated 14,000 cases in 2023 in the United States, representing 0.7% of all new cancer cases. And if you look on the right side of the screen, you can sort of see that the rate of new cases has gone down quite nicely over time in the United States, and the death rate, thankfully, has also gone down as well. But the thing that I want to really point out is on the left side of the screen here. The 5-year survival, the way that, the success we have at treating cervical cancer is really prominent in when it's localized, meaning it's confined to the cervix. And our success rates at survival and cure are pretty high. However, the success rates go down once we deal with regional disease, meaning it's spread outside of the cervix, or distant disease, meaning it's spread to other sites. So the real trick here is capturing, or ideally preventing cancer, but at the very least capturing it in the early stage, and it's localized and much more treatable. And this is, the real success that's come from preventing and screening for cervical cancer revolves around the human papillomavirus, or the HPV virus. The HPV, I'm going to go off on a little bit of a tangent. The HPV virus it's a virus, and it is one of the few viruses we know of that is responsible for cancer. HPV can cause several different types of cancers. It's related to cervical cancer, anal cancer, vulvar, vaginal, penile, and oral cancers. One of the biggest connections has been with cervix, which I'll talk a little bit more about. The HPV is a circular, double-stranded DNA virus, obviously less important, but it is known to affect all sites of the anogenital tract, from the mouth all the way to the anus. And there's about 40 types that have been distinctly identified, and we sort of classify them by their potential to cause cancer. Okay, there's basically a low-risk group and a high-risk group. The low-risk group encompasses at least 5 HPV types, or when I say types, I mean different types of the virus, different mutations of the virus. And these low-risk groups can cause symptoms. They can cause genital warts or other benign lesions, but they are not associated with risk of turning into cancer. The high-risk HPV groups are associated with cancer. HPV type 16, 18, 31, 33, and so on are all associated with development or evolution into cervical cancer. 16 and 18 more so. The most common types in the United States are HPV type 16 and 18, which are responsible for about 70% of all cervical cancers. And the thing that I want to sort of highlight is that HPV is necessary for cervical cancer. HPV sequences have been detected in over 99% of cervical cancers. So it's almost impossible for cervical cancer to develop without the infection of an HPV virus. The association between HPV and cervix cancer is higher than that between smoking and lung cancer. Okay, so there's more than 40 types, like I had said. There's low risk and high risk types, and this is a virus that is sexually transmitted. It is the most common sexually transmitted infection. So just as an example here, here's a diagram. If you were to take all people with the cervix and put them in a large circle, that's what we have here. So all people with the cervix are represented by this pinkish tannish circle. And now the prevalence of the HPV virus is actually quite high. Over the course of a lifetime, most people will get the HPV virus. About 80% of females will get the HPV virus. But not everybody with the HPV virus. So not everybody with the cervix will get an HPV virus, but the majority will. But you look at, but within those that get the HPV virus, a very small percentage of them will have abnormal cervical cells. When I say abnormal cervical cells, that means abnormalities found on a pap smear. And then of those individuals that have an abnormal pap smear, only a small percentage of those will be found to have CIN2 and CIN3. CIN2 and CIN3 are precancerous changes, which I'll talk more about. So not everybody with the cervix will get the HPV virus, but only those with an HPV virus will get abnormalities in their pap smears and get precancerous changes. And of those with the precancerous changes, only a small percentage of those will get cervical cancer. So a lot needs to happen in order for an individual to progress to cervical cancer. In the United States, the lifetime risk for sexually active men and women is at least 50%. But yeah, as I said, by 50 years of age, over 80% of women will have acquired the genital HPV infection. So it's a very, very common infection. The estimated incidence is about 6 million per year, and the point prevalence rate, meaning if you were to look at a snapshot of every single individual, at any given time, about 27% of them will have the HPV infection. The highest prevalence rate is in women between the ages of 20 and 25. So when I talk to patients about the HPV virus, they'll ask, how did I get this? And is it an STI? Is it a sexually transmitted infection? The answer is, it's like your cervix caught a cold. Okay, it's a virus. It is transmitted through, it's a sexually transmitted infection. But for the majority of people, the vast majority of people, it's a very benign or mild virus. It causes basically no symptoms. It just causes changes in the cells that line the cervix. And this is sort of a pathway to cervical cancer. Okay, there's an exposure, and that exposure, usually it's through sexual activity, leads to an HPV infection. Now, the majority of HPV infections will either go away or go into a latent phase where they don't cause any, they basically just get fought off by the body's immune system. Some HPV infections will progress into CIN2 and CIN1 and CIN2. And I'll talk more about that, but CIN is a cervical intraepithelial neoplasia, which is a fancy word for precancer. And precancerous changes are graded between 1, 2, and 3. As you can imagine, a grade 1 is a low grade or less likely to become malignant, and grade 3 is a high grade precancer, which is more likely to become malignant. So CIN1 and CIN2, so the HPV infection can cause changes to develop into CIN1, CIN2, but those typically go away on their own. They typically go back. That's why the arrow is double-sided. So the HPV virus will cause CIN1 and CIN2, but then most of the time it will regress. But some individuals with HPV infection will develop a persistent infection, and that's where the changes happen. It's not necessarily getting the infection, it's having a persistent infection. Your body, for one reason or another, does not clear the infection. And that can lead to higher grade changes. It can lead to a CIN2, which is sort of that middle grade precancer, and CIN3, which is that high grade precancer, and that can lead into cancer. This slide just sort of shows the terminology that we use. And these are terminologies that you've probably read in various pap smear reports, but it's important just to sort of at least have a background on it. There's something called the Bethesda classification, and that is the terminology that we use to describe a pap smear. When one gets a pap smear, the physician will basically get you sort of brush and sweep the cervix, and you sweep up cells and put it into a solution, and that solution has like these cells floating around, and a cytotechnologist can look and define whether they have changes. Okay, on the left here, that's a normal pap smear, and right next to it is something called ascus, or atypical squamous cells of unclear significance, and then L-sil and H-sil. L-sil are low-grade squamous intraepithelial lesions, or low-grade changes, and H-sil are high-grade changes. And these are all things that we can note on a pap smear. When I talked about CIN1, CIN2, and CIN3 before, that's different. That's when one takes a biopsy. When one takes a biopsy, you're not just sweeping up cells that are free floating anymore. You're actually getting a sample of cells within tissue. So you can sort of see the architecture of those cells. And you can say, well, this cell looks abnormal, but in the grand scheme, it actually doesn't look that abnormal. That could be mild dysplasia, or CIN1. Or you can say, yes, there's an abnormal cell, and it's in the background of very abnormal cells. and that could be high-grade dysplasia. So the CIN or WHO histopathology, those terms on the second line here come from an actual biopsy. So not just a pap smear where we're sweeping cells from the cervix and putting it in a solution. We're talking about a biopsy where you take a sample, you take an actual, bite of tissue, so to speak, and that can be looked at and you can tell. So L-cell or low-grade squamous intraepithelial lesions tend to correlate well with CIN1, and H-cell high-grade squamous intraepithelial lesions tend to correlate with CIN2 and CIN3. So it's not a given, but they tend to correlate well with one another. And here's sort of how the biology of an HPV infection works. Okay, these are the cells that line your cervix. The blue is the area that's the cervix is exposed to in the vagina, and the bottom layer here, that's the basal cell layer, and that's sort of the final line that protects your body from anything that's in the vagina. And the infectious viral particle, so the HPV virus will implant itself and ingrain itself within the lines, within the cells that line the cervix, and it creates episomes, and they basically create changes within the cellular DNA, and those cells start to look abnormal. So when I say that you see an abnormal cell on a microscope, when a pathologist looks at a sampling, when the pathologist looks at a biopsy, you can see not just one abnormal cell, but you can see the entire architecture of the cells. So if it only is affecting, the outer third, then we call it CIN1. When it's affecting the middle third, CIN2, and when it's affecting the deep third, the bottom or the basal cell layer, that's CIN3 or high-grade dysplasia. And of course, when it goes through the basal cell layer, when the cells are so abnormal that they're actually breaking through that layer and turning into and starting to invade and spread, that's cancer. And here's another diagram, just sort of trying to beat it in as much as I can. But if you look at a very close-up microscopic view of the cervix, the outer layer is right here, and the inner layer, that basal cell layer, is that final line. And you can see as the low-grade changes happen, the cells look abnormal, and the high-grade changes happen, they look severely abnormal. And when you develop into cancer, that's when it breaks through that bottom layer. So I'll say it again now, but most HPV infections become undetectable within 3 years. Okay, this slide here, the purple shows that if you took a series of women who had the HPV virus and followed them over a span of 7 years, the majority, about 90% of them, have cleared. Okay, that's represented by the purple in this graph. The green are those that persist. So over time, the persistent infection goes down. Okay, but ones that progress, the ones that progress to high-grade dysplasia and potentially cancer, that goes up. So it's those persistent HPV infections that are the ones responsible for most of these cancers. So here's how we screen women for cervical cancer. Less than 21 years old, we don't screen, but once you turn 21, there's a variety of ways to do it. I won't go into all the methods, but it typically involves testing either the cytology, meaning getting a pap smear, or testing the HPV, meaning we actually run the sample to test for the HPV virus every 3 to 5 years. Once you hit the age of 65 and you've had adequate negative screening beforehand, then you've sort of screened out. You don't need to screen anymore for cervical cancer. And of course, there are special situations for people who've had a prior hysterectomy. So how does one manage abnormal pap smear? So you have a pap smear and the pap smear comes back normal, great. You follow up in 3 to 5 years. If it's an abnormal pap smear, there's basically two main follow-ups. One is a colposcopy and the other is an excision. Colposcopy is it's an intervention. It's a procedure in which the gynecologist will actually use a microscope to look at the cells of the cervix. First, you stain the cells with acetic acid, and then you look to see for certain changes that would indicate dysplasia or indicate precancer. And you can look very closely under the microscope and take specific targeted biopsies of those areas. And then excision. Excision is when one finds a high-grade dysplasia. If one finds a CAM2 or CAM3, you find a high-grade change that can lead to cancer, the goal is to excise it. And there's two ways to do it. One is something called a loop electrosurgical excision procedure, where you use an electrocautery wire to sort of coagulate off those areas. And the other is what's called a cone biopsy, where you use a scalpel to do it. But either one of those are efficient at removing the majority of high-grade changes and preventing cancer. So the algorithm that we use to determine if one should have, what's the algorithm, what's the protocol for managing dysplasia, what's the protocol for managing an abnormal pap smear? The answer lies in whether the immediate risk of a high-grade change, a CAM3 or higher, is 4%. Okay, that's come from a series of large population-based studies. If the risk is less than 4% of, and that risk is calculated already. This isn't something that we have to do in the office, but it's a calculated risk. If it's lower than 4%, then you basically ask that patient to come back 1, 3, or 5 years later, and you sort of risk stratify them based on their overall risk. And that can include sort of the cytology, meaning what the pap smear showed, and it can also include their unique risk for developing cancer, which I won't belabor, but there are certain follow-up intervals that we use. But if that risk of CAM3 or higher is more than 4%, then that automatically puts them into a higher risk category that requires something. Either requires a colposcopy, where again, we look with a microscope and target biopsy those areas to make sure there's no precancerous changes, or some patients in which the risk is very high, 60 to 100%, we do what's called expedited treatment, meaning we just take them and do an excision. You want to excise the abnormal tissue out. You don't need to do any more workups. So when one gets an abnormal pap smear, the protocol, like the algorithm on what to do next, can depend. It can anywhere from 1 to 5 year follow-up, or having a biopsy or an excision. So regular pap screening decreases cervix cancer incidence and mortality by at least 80%. The goal of this, remember, the overarching goal here is to reduce either prevent cancer, like find the changes that are leading to cancer and nip it in the bud, excise those abnormal cells, or at the worst is to catch these cancers early and when they're more curable. And so regular pap screening has been shown to reduce both incidence, meaning people getting cancer, and mortality, people dying from cancer, by at least 80%. And that leads me to the HPV vaccine. Where does the HPV vaccine fit in all this? The HPV vaccine is actually quite new. So recall, the HPV virus is necessary for cervical cancer. This is something that I was showing before, but the HPV, you need to get HPV in order to get cervical cancer. So in theory, HPV prevention should reduce cervical cancer risk. And the goal of any sort of HPV prevention, any sort of viral prevention would, you would imagine, target those high-risk groups, the ones that are much more likely to turn into a cancer. So here's a list of the 3 main HPV vaccines. Okay, in 2006, a quadrivalent vaccine called Gardasil was FDA approved. It's quadrivalent, meaning it targeted 4 different strains of the HPV virus, 6, 11, 16, and 18. So it targeted the 4 most common ones, the 2 common low-risk ones that cause genital warts, and the 2 high-risk ones. Remember, 16 and 18 accounts for 70% of cervical cancer. So once the Gardasil came out, women were inoculated. That would prevent, or at least significantly reduce, the chances of getting those viruses. In 2007, a different one was FDA approved, the bivalent one, or Cervarix. It only protected against 16 and 18. And then in 2014, the 9-valent vaccine, or also called Gardasil, which, as the name suggests, protects against 9 different strains of the HPV virus, was released. And nowadays, it's basically the standard of care. I'm pretty sure you only get the 9-valent vaccine in the United States. And in addition to protecting against 6 and 11, the 2 low-risk HPV viruses, it protects against 16, 18, 31, 33, 45, 52, and 58, all the high-risk types. So it's greatly efficacious at reducing the chances of getting high-risk HPV infections. So HPV vaccination prior to the age of 18 reduces the risk of CM3 by at least 50%. I'll actually show some different data on that too. But the data on how well it's reduced cancer it's taken a while to come out, because these vaccines have been around for only 20 years basically, and it takes a long time. It takes a long time for people to get cervical cancer. Cervical cancer is still a very rare cancer, and so it takes time to sort of see these changes play out in the world. And so these patients are now just reaching their early 20s, and it's also hard and it's challenging to know, who has been vaccinated. Documentation of vaccination and age is necessary and challenging, and as I'll kind of show, vaccination status will likely impact the age to start screening in the future. So the question is, can HPV vaccination prevent cervical cancer? This was answered a few years ago in a large study that was published in the New England Journal of Medicine. And this was not a randomized trial. This is a population-based study. In Sweden, they have large population databases, and they looked at over 1,600,000 women with no prior HPV vaccination and no prior diagnosis of cancer. And they looked, about 1 million of them did not receive the HPV vaccine, and about 500,000 of them did. And as you can see, 19 of the women that received the vaccine developed cervical cancer, whereas 538 of women that did not receive the vaccine developed cervical cancer. And this graph, the x-axis of the graph shows age. So as age goes up, the incidence of cancer, which is on the y-axis, is expected to go up. So that red line represents the unvaccinated patients in this population. And you can see over time that the incidence of cancer started going up around the ages of 24, and that went up in a more exponential type pattern. Those that got vaccinated between the ages of 17 and 30 had a rise, but a much slower, it's not as the slope is less. And then those that got vaccinated at a younger age, less than the age of 17, had significantly lower chances of getting cancer. So overall, in this study, getting the HPV vaccine reduced the risk of cervical cancer by 70 to 90%. Quite remarkable. And there's been plenty of other studies showing just that. So this is, it's a real game changer, both in prevention of cancer and, again, catching cancer at an earlier stage and making it more curable. So when does one vaccinate? The ACIP recommends routine vaccination for the HPV virus between the ages of 11 and 12. It can be given as young as ages as 9. But as long as you start getting the vaccine before the age of 15, you can get 2 doses 2 months apart. If you get it after the age of 15, then you should get it in 3 doses. One, the first dose, and then the second one 2 months apart, and the third one 6 months after, or 4 months after, but 6 months after the first dose. So when one receives all or is fully vaccinated, then they're fully protected. The question, this is sort of came up about 6 years ago now, but the 9-valent HPV vaccine was FDA approved in 2018 for individuals up to the age of 45. And so it wasn't fully recommended. It says vaccination of persons 27 through 45 can be considered based on shared clinical decision making. Okay, so what are the things to consider? Well, while the prophylactic administration of the vaccine was efficacious, that was effective in young women who have never had the virus before. But the question on how effective it would be at women that have already been infected is less known. And as you recall, the incidence, any individual has about an 80% chance of getting the HPV virus during their lifetime. So if one has already been infected with the virus, it's unclear how efficacious it would be to get a vaccine. Consider that along with the fact that there are global shortages of vaccines, and if we were, you want to sort of concentrate them where they could get the biggest sort of bang for their buck. You want to use them in areas that have higher than normal HPV infection rates, and you want to capture them in younger patients before they get the HPV virus. It is also known, recall, that the persistent infection is the one that causes disease. So less is known about the natural history of new infections. So it's those that get infected, so to speak, at the age of 15, 17, 20, 24. Those young ages are way more likely, if persistent, to cause high risk disease than it would be to get the HPV virus in your 40s. So it's unclear how beneficial it would be for a mid-adult woman to get the virus, the viral vaccine. Nevertheless, it is available. There are a series of supplemental guidances on, if you start the vaccine series with one type, can we complete it with the other type? Again, less of an issue because everyone now is using the 9-valent. But here's sort of a synopsis. Between the ages of 11 and 12, you should start routine vaccination. Between 13 and 26, you can catch up. Between 27 and 45, you can do shared clinical decision making. One thing that I will talk a little bit more about before I end is using the vaccine in women after high-grade dysplasia is found. So post-excision, HPV vaccination can reduce recurrence. This is something that's been known for quite a bit, but the data has gotten stronger over the last few years. What does this mean? This means that women who see their gynecologist for abnormal pap smears, let's say you had an abnormal pap smear and it was found to be a high risk, you had CIN2 or CIN3, you had a high grade precancer. And the typical thing that happens is that's treated. That area gets excised, and then hopefully it never, and then we sort of watch and ensure that it doesn't come back. Well, it turns out in women who have never been vaccinated for the HPV vaccine, if after you excise the abnormal precancerous tissue, you give the vaccine, it can actually significantly reduce recurrences. This was a randomized trial published in 2020, in which 300 women with high-grade dysplasia, those CIN2, CIN3 changes, they were treated, that area was treated, and then they were given, some women were given the vaccine and some were not. And I'll just kind of go over to the right side here, the effectiveness, 52 to 63%. So giving the vaccine after being treated for a high-grade dysplasia can reduce the chances of getting reinfected by up to 60%. So very important, and something that I talk with my patients about, and I would encourage anybody that is in a situation like this to talk to their physician about too. And that's all I have.